In the dialysis, we have seen about ultrafiltrate removal, but many are residents having the doubt in situations of nil urine output. How to decide on the ultrafiltrate? To solve this, first we have to know what is the context of that nil urine output. It can be in AKI, it can be in a CKD patient. CKD5 dialysis patient, if eventually urine output is nil, admitted for some other reason, no issue, you can remove whatever the ultrafiltrate required to keep the patient euvolemic. So for a CKD patient who is already in stage, already urine output is nil, you remove ultrafiltrate even if the patient urine output is nil, there won't be an issue. The problem happens in a situation where patient is a case of acute kidney injury. Before admission, urine output was fine. After admission, patient urine output, probably because of that particular reason, patient got admitted. First, you have to rule out post-renal cause. Why the urine output was nil? Since the patient is under medicine department, probably a kind of renal or pre-renal injury. Two parameters, the chances of recovery and the patient volume status now. If the patient is in severe pulmonary edema or any kind of volume overload which is precipitating the current worsening, that time we can't wait for the urine output to come. So we have to focus on the ultrafiltrate removal. Whatever the ultrafiltrate we are removing, okay fine, urine output is not going to come, but our main focus is to stabilize the patient. Stabilize the patient volume wise. Stabilize the patient to bring the patient out of MODS mostly. Hepatitis is there, patient inotropic support is there. That time we have to focus on the primary thing to stabilize the patient. We have to remove ultrafiltrate. Urine output is not a criteria. Nil urine output. If I remove ultrafiltrate, urine output will be zero. That concept we can't think because we have to bring the patient out of that particular volume overload status. Let us take another situation where we are expecting recovery. Patient nil urine output is there. Patient came with pre-renal injury, but you are expecting a very good renal recovery. During that time, you have to leave the patient bit volume overloaded. A mild overload state is required so that urine output will start producing. That is why the stages of AKI you have to be aware of. Initiation phase, maintenance phase, polyuric phase. If the patient is in initiation phase, unlikely urine output will come the next day unless severity is very mild. So if the severity is very mild, you can keep the patient bit in the volume overload state. Not to the level patient is having SOB, severe shortness of breath. To the level patient is mild discomfort, but overload is there. In a patient with nil urine output, you have to remove less ultrafiltrate, considering the volume status. The patient is in the second phase, maintenance phase. We are expecting the recovery. From ICU, I shifted the patient to the ward. From ward, I shifted the patient to even at the time of discharge we are planning. That time also urine output is nil, but we are expecting recovery. That means it can't be zero, it can be 200 ml, 300 ml. During that time, better to reduce the ultrafiltrate. In the sense, if we are planning to remove 1 liter, reduce only 300 ml. Because we will be keeping the patient in follow-up so that the start of urine output won't be hampered. So in conclusion, for the medicine PG, what you people have to assess? Recovery and the current sick status of the patient. If you are targeting recovery, ultrafiltrate, be cautious. Don't remove or remove very less. And if you want to stabilize the patient, make the patient euvolemic. These two. These you might not find in the textbook. Probably with your nephro posting only you will come to know. Many a time, even with respect to the dialysis indication, Harrison, the contents are not clear. So as you complete your posting or during your MD curriculum, you will come to know these practical things. Recovery is the important one with respect to AKI. Some final year will have doubts. Sir, CKD5 patient with urine output, what to do? That we will discuss separately. CKD5 patient can have urine output. Why? Only in chronic glomerulonephritis, patient usually urine output goes and stop. Whereas in tubulointerstitial disease, still urine output is always there. That is called a residual urine output. Again, the parameters in one line, the parameters are similar to, we have to maintain that residual urine output. Always try to maintain. If patient is so sick, we have to focus on the sick status of the patient rather than RUO, residual urine output. So if the patient is stable, focus on maintaining the RUO. This is for the final MDs who have the doubt, sir, CKD5, why the urine output is there? Yes, they can have it. Bye-bye.